So in terms of our ARV journey, we've also progressed in like 20, 25 years from having a handful of ARVs in the morning and a handful of ARVs in the night, and not just like a handful in the morning. The drugs will also have massive side effects, but that's all we had at the time, and that's all we had to roll out. But I think the condom era is in the past. We would show patients how to put a condom over the model penises. Now we say to patients, your viral load is undetectable. You don't need a condom. And don't ever think about the ARVs and the HIV ever. It doesn't even exist if your viral load is undetectable.
Greetings and welcome to MOL Out Loud, the MOL podcast. My name is Moli Mutseotada, and today we have with us Dr. Kay Mahomed. Dr. Kay is an HIV clinician, and she is here to share with us all that we need to know about her journey as an HIV clinician. Welcome, Dr. Kay.
Thank you so much for the introduction.
How are you?
I'm in the best of health, and I must say I'm in a good space.
I'm glad to hear that, and we are grateful that you've made time for us. We know how busy your schedule is, and just in terms of starting the conversation, would you mind telling us what you studied in medical school and how you landed in the HIV specialty space?
So it's a funny thing, now I'm going to be giving my age away, but we had our 40th reunion last year. So I qualified for med school 40 years ago.
Wow. But you still look so good.
I think you're very complimentary, but anyways. And then I went on to have 4 kids as well.
Wow.
With a husband. And then as the kids grew up, raising a bunch of kids and working full time became a bit of a problem. So I'm sure all the mothers out there and professional women would understand this, that women have many balls in the air while men just go to work and come back. And
True.
We've got to do 101 more things than they do. And then for a while I stopped working and I started raising 4 kids.
So just to take you back just a little bit, Dr. K, when you were working, which field were you in? What were you focused on?
Initially, I was doing a whole lot of anesthetics medicine. And then when I married, I started working at the Hillbrow Casualty. And I thoroughly enjoyed it. They thoroughly enjoyed having me as well because I was absolutely good with CVPs, lines, resusces. So it just worked for them and for me. But then with 4 kids and all of them being breastfed as well, at some point in time, I had to say, I need to take some time off here, which is when I left after a little while. And then one day, I have to share the story. I was sitting at the gym with the 4 kids having a swimming lesson, and I bumped into an old colleague who worked with me at Hillbrow Hospital. And he was absolutely horrified that here was I sitting in the gym, not using the gym, like a queen, he said. He thought it was disgusting. So he said to me, and the colleague was Dr. Dennis Rubel, he said to me, Kay, I want you to come to Helen Joseph tomorrow. And that was in January 2005.
And it had been how long with you being a stay-at-home mom?
I must have been a stay-at-home mom for like 5 or 6 years.
Wow. Okay.
And then I had no idea where Helen Joseph was, but I got there the next day and he told me where to get to. And there was an NGO in 2005 called Right to Care that worked from Helen Joseph Hospital. So I go in there and at Helen Joseph, but not behind Helen Joseph is where Right to Care worked from the NGO that rolled out ARVs at the time. The CEO was there, Ian Zana, and he wanted to know from me what did I know about HIV. And I knew absolutely nothing.
Wow.
And I said to him nothing. And then Dennis said to him, don't worry about Kay. She comes from an era of where You see one, you do one, you teach one.
Mm.
And Dennis said, if you come so highly recommended, go and see the next CEO, who was Dr. Tembi Zulu. And she said to me, Kay, I'm sure you're going to run this clinic. Go to HR. And that was at Friday, January 2005. And on Monday, I was on their payroll and I had started working at Right to Care. Now, let me just tell you how it worked at Right to Care. At that time, the government hadn't come on board yet with ARVs. And we saw an average of about 800 patients a day.
In 2005?
In 2005 at Right to Care.
Sure.
So I sat next to Dennis Rubel for a month, and he taught me everything I needed to know, and I can't even tell you. There was so much to learn. It was just like so wonderful because the field was new. The medicines were just starting to get rolled out. It was President Zuma who was there at the time, and he came on board and we started rolling out the ARVs, and it was like the greatest thing anyone could have been exposed to, because from having no ARVs to all of a sudden having some ARVs was like game changing, because you were giving life back to people.
Wow, very interesting. Before we delve deeper into the journey at Right to Care, I would like you to explain. There is a huge confusion for people that don't know the difference between HIV and AIDS. I grew up in the township, and when people did get sick and people diagnosed with their eyes, they would say, he or she's got AIDS. So I would like you to explain to us the difference.
All right. There is a big difference between HIV and AIDS. What HIV means is the virus. It stands for the virus, the human immunodeficiency virus. That is HIV, refers to the virus. Now, generally what happens when you contract the virus, we have many phases we go through. So we used to have from phase 1 to phase 4, and that was just based clinically. So in the old days, we didn't have access to a lot of bloods and all of that. So clinically, we'd look at you and say, you in stage 1, you in stage 2, you in stage 3, and you in stage 4. So stage 1 of people having the virus means that they were asymptomatic, or they had very, very minor symptoms. And then stage 2 got a little bit more complex. But stage 4 is what we called AIDS. And stage 4 is when you had disseminated disease. What I mean by disseminated disease, you didn't just have the virus, you had all the virus cousins going with it as well. Like you would have TB and CMV and meningitis and a whole lot of weight loss and all the extreme complications going with the virus, and that we would call AIDS, stage 4. So stage 1 was simple asymptomatic, stage 2 will be simple infections like skin and chest. Stage 3 would be a little more complicated, but stage 4 is what some would call full-blown AIDS, or what I would say the virus with other infections and a severe form of the virus. So it's the virus in different stages, because at the time we treat patients not so much on bloods. It was clinically we staged you, and then we went stage 1 to stage 4, and stage 4 means you had disseminated serious disease, and that was AIDS.
Okay. All right. So as this process started of rolling out ARVs, what were some of the biggest challenges that you guys experienced?
I think you must remember it started from the head, right? And remember we came through an era where the people who rule the country denied the illness. So I'm not going to name any names, but we know people said you needed to eat beetroot and potatoes and a whole lot of nonsense that was being said at the time. But what it really boiled down to was you had a virus, you needed to go on to ARVs. And that is how straightforward it was. So what we did, we started putting patients onto ARVs, And at the time, the ARVs we had were not like as advanced as the ones we have nowadays, is what was available at the time. So in terms of our ARV journey, we've also progressed in like 20, 25 years from having a handful of ARVs in the morning and a handful of ARVs in the night, and not just like a handful in the morning. The drugs will also have massive side effects, but that's all we had at the time, and that's all we had to roll out. But having said that, it's completely different now.
Sure, I believe so. And the numbers that you are mentioning, just at the top of your head, like you said, almost 800 patients per day
in one clinic.
In one clinic in South Africa, in the year 2005. Once the rollout of ARVs started, did the numbers decrease or they kept increasing?
The numbers didn't decrease, but our efficiency got better. So remember, in the old days, the only time you could access ARVs was from an NGO that was being funded with foreign aid. Then when Zuma came along, President Zuma, he rolled out the ARVs. And then we not only started giving it at all our hospitals, we started giving it to all the clinics. And also we gotten even smarter, and this was also an initiative of Right to Care, where we started training nurses as well. So you could have nurse-initiated ARVs. So now you can access your ARVs from any government hospital, any government clinic. It is right at your doorstep.
Sure. Okay. So now, in that journey, Dr. Kay, what are some of the most challenging patients or situations that you've had, specifically when it came to pregnancy or to somebody not responding well to the treatment? How did you guys deal with such?
It's been a wonderful journey, right? So I'm just going to start with pregnancy, for example. I'm just looking at just how pregnant women have moved on in life. So remember, in the old days, pregnant women only got treatment very much later on. So we would decide on whether you needed treatment, didn't need treatment, depending on your CD4. And then we gave you treatment just later on, you know, when you were delivering a baby, and that too was like wishy-washy. All of that is in the past. Now what we're doing is we're putting everyone who's pregnant on ARVs as soon as they're pregnant, so that firstly, mum goes on to do well, the babies are never infected. And just by doing that PMTCT, like prevention of mother-to-child transmission, we brought the transmission rate literally to like less than 1%, 2%. So we saved all those babies from being seroconverted, which previously would have sat at 25%, and now we moved it to less than 2%. So just by ensuring that every mother who came into the clinics, for whatever reason, got tested and got put onto treatment immediately, we just changed that whole face of how women reacted to HIV in them days. And now if you got the mum into care, you made sure that the babies were negative. And also, if you were smarter, when you got mum into care, you also brought dad into care as well. So the whole field has changed. So what I mean to say, not just with the pregnancy that is the major turnaround. So remember, in the old days, it was all dependent on CD4s and what stage you were on before you got into treatment, and you were sick before you got into treatment. The test and treat program changed that completely. So what we are saying, every person out there needs to test, and as soon as you test, you go into treatment. And what this does for you is allows you, the individual, to never be ill. To never ever have to say, I have HIV issues, because you're not going to have no HIV issues. You're going to lead a completely normal life. So previously, if your lifespan used to be 40 years, I now say to people, you're going to live forever, because previously I had a patient, I told him you live to 80, he was very upset because he was going to live forever. So everyone is going to live forever. Not only are you going to live forever, but if your viral load is undetectable, you're not going to pass the virus to anyone else, not to a child and not to a partner, even if no condom is used.
Sure. We'll come back to that. I wanted you to clarify for somebody that's watching now, when you say prevention, to that teenager who hasn't yet engaged in sexual activity, to an adult who's already sexually active, what is prevention?
Prevention is being smart. End of story. You need to take your health into your own hands, right? So the start point of prevention, and like I say, equals being smart, you need to test. If you test and you're positive, you go into treatment. If you test and you're negative, you go into PrEP. So we need to just sort out the two issues here. So you test, you're positive, you go into treatment. You take one tablet every morning for the rest of your life, you're as good as anyone who's HIV negative. And for as long as that viral load is undetectable, I'm telling you, you're as good as anyone who's HIV negative. You just need to throw the stigma behind you and move on in life. If you're HIV negative, you have two options. You can either depend on your partner's viral load. If undetectable, you know you'll never get HIV from that person. Or you can take your health into your own hands and take PrEP. So PrEP is pre-exposure prevention. So you're HIV negative, we're going to give you a tablet, one tablet every morning that will ensure you will never get HIV. And this is not even taking into account a partner. This is you making that decision where you are comfortable. But having said that, so remember we talked about an undetectable viral load ensures you don't transmit, people remain negative. We talked about the PrEP where you take one tablet every day and that makes sure you don't get HIV, so you're not dependent on anyone else's viral load. You've protected yourself. And this year, around about April, we will be rolling out PrEP injectables. So you'll be able to access one injection every 6 months, and that makes sure you'll be HIV negative. So I think this is going to be a major game changer, especially in women, especially in girls, especially in the youth. We need to let everyone out there know that this will become available. You go out, you test. If you're negative and you want to access PrEP, there's an injectable available, and we women know all about injectables because of prevention. So one injection will prevent you from getting HIV, and it's 2 injections a year.
Sure. I hear you. I hear everything that you're mentioning. Are all these treatments being made or being created because people are just not using condoms? I'm going to put it that bluntly.
So you obviously can see the 2 eras we've come from.
Yeah.
You from before my era, I'm from after my era. Maybe you old-fashioned, I'm not. I don't know. But I think the condom era is in the past. The condom era is in the past. You know, I remember when I started at Right to Care, we would show patients how to put a condom over the model penises. Now we say to patients, your viral load isn't undetectable. You don't need a condom. You need an undetectable viral load, or you need PrEP. So my personal opinion is I think the condoms are in the past.
Wow, that's a very interesting fact. And I also asked you a question when we spoke about pregnant mothers. Have you had cases where someone will test positive and they are put on ARVs and their body or immune system is just not responding to the treatment? What happens in that situation?
If you're my patient, I will kill you. Because that is telling me you're not taking your meds. End of story. That's how ARVs work.
Oh.
They work. So let me just tell you the scenario with the pregnant women. Remember, we test women throughout the pregnancy, even if you're negative. So if you're negative, we will test you throughout the pregnancy every 3 months and before you deliver, because you could pick it up later on down the line. So there is no reason for any seroconversion to be happening anywhere along the line. We on top of things. And if you are on treatment, you need to have an undetectable viral load, and that is non-negotiable. Not just if you're pregnant, just for yourself. And that's why I say if you have a viral load that is detectable, I literally will kill you.
Sure.
And you don't need to be pregnant to get killed either, because it is so easy. You take 1 tablet every morning, and you are as good as anyone who's HIV negative. And the drugs have no side effects. And I mean no side effects. You don't get drowsy, you don't get dizzy, and whatever you're feeling, you just come to us and we will work around it. Whether you have a kidney problem, whether you have a liver problem, whatever problem you have, we will work around it. This is where we are with our drugs now. We have kidney-friendly drugs, we have liver-friendly drugs. You fail on our treatment, we have other drugs if we haven't already killed you.
Wow, okay. Very, very interesting. So now, you're still at Right to Care. How many years did you spend in that space?
I was at Right to Care from 2005 until 2015.
Sure.
And then, kids come along and they change your lives, like when they first changed my life when I got to Right to Care. And then in 2015, I had a son who was in grade 7. And at a private school, the mums play a very active role, and he was captain of the cricket team, hockey team, soccer team, every team you could think of, and they needed a hands-on mum there. And so I had to then leave Right to Care, where I had learned everything about HIV and its comorbidities, and I came to Garden City Hospital and I opened my own practice, because then I could have flexi hours. And then it started off as a 9 to 12 day, and now it's a 9 to 4 day. Let's see if I can get home at 4 as well.
And if your patients had their way, it would be a 7-day open, always open surgery, I'm sure.
In a way, I have the best patients, because and I'm saying this because I do have the best patients. Like I say, and the reason I'm saying I have the best patients, there's not a single one who's virally undetectable. Everyone has an undetectable viral load. And I mean, every single patient of mine is virally undetectable. And what I find is that the confidence you have as a doctor and the knowledge needs to be passed on to that patient. And then they look after themselves. I mean, this morning, I saw a gentleman, he said to me, "Dr. Kay, do you remember me?" And I said, "Of course, how can I not? The 3 of you were my first 3 patients I ever saw at Garden City, in the ICU, all 3 on ventilators, and I've never forgotten that day ever, and I would never ever forget you guys either." In fact, one of the patients, he comes into my rooms, and he comes here not looking for his doctor. He comes here looking for his darling.
Oh, wow, and that's you.
And he says, "And I would call you darling in front of your husband as well, Dr. Kay."
Speaking about your husband, how has your family maneuvered through this journey? How has it affected them, your children? How has it been for them? Because I can tell how passionate you are about the work you do.
So Dad is a super professional in his field. And they're all very proud about Dad. And Mum was just Mum, and no one knew very much about Mum. And then we would walk around the park, so we would be shopping, and people would go, "Hello, Dr. Kay," which is when my kids realized, "Yo, Mum, you do make a difference."
Oh my goodness, you were just Mom.
I was always just Mum.
Wow.
And then we would, like I say, be in a shopping mall or in a supermarket, and people would go, "Hello, Dr. Kay," and then kids would go, "Yo, Mum, you really have touched people's lives."
Wow, that's very interesting. And where you are at now, what more change do you want to see? I know there is the 2030 target. Where do you think we are as a country regarding that?
I think we're in a wonderful space. I know we said we want most people tested. We want most people undetectable. And I think we've really rolled out really very nicely. We're doing extensive testing. We have patients on treatment. I trust everyone is being very strict with their patients, like I am as well. So I think we'll get to the target. We've just had a little bit of a glitch with the foreign funding recently that has been withdrawn, but I don't think that has affected too badly the man on the street, because like I did say, the government did pick up the rollout in President Zuma's time, and it is being rolled out massively. I think the research has been put on stall, and I must say, I think I say this to the kids as well, one of the best fields of medicines to be practicing is HIV. Everyone is just doing so well. The patients are doing so well. The doctor's very happy.
Yes. Yes.
If there's one field of medicine where you've made a huge difference in people's lives, where I can tell you, just go out and live your best life and forget the HIV. It doesn't exist anymore. It exists in my bin, which is what I say to patients as well. You see the stigma, you dump it in the bin before you leave here, and don't ever think about the ARVs and the HIV ever. It doesn't even exist if your viral load is undetectable. So I don't think there are very many fields of medicine where any speciality can tell you that. Go out and lead your best life. In fact, I have to share this with you. In my own practice, my patients are having their 4th children with me.
Sure.
I think they're competing with me.
Most of them are having 4 children.
Yes. And
wow.
If you can afford them, why not?
Yeah, that's very interesting. And I wanted to ask you, you brought it up just now, the stigma issue. How have you helped your patients overcome that? And what can be done for people that have been counseled, are taking their ARVs, but the stigma thing is just not leaving them?
So I think the biggest thing to counteract stigma is in education. So it's not just about treating people. If you've educated them, you've sorted it out, and they will sort themselves out. So it's quite simple, and what I generally say to patients is it's just exactly like I'm telling it to you. You have a virus, that's where the virus is. We give you ARVs, the virus goes there, this is where your ARVs are. And for as long as you hold that balance, you're as good as anyone who's HIV negative. The day you stop your drugs, your drug level comes down and your virus climbs up again. So that's what you don't want. And I think for as long as you say to people, listen, it's 1 tablet every morning when you get up, and you can't tell me you're going to forget, because you're not. What's the first thing you do when you get up? You go to the bathroom. When you go to the bathroom is when you drink your meds. So it's not even like in the old days, we used to have 8 o'clock, time.
Oh yes, there was a certain time.
Like that anymore.
Oh.
Doesn't. So I'm saying to you, what's the first thing you do when you get up? You go to the bathroom. You drink your meds, it's done. You don't even have to remember it. You don't even have to remember to take your meds. Whereas if you were taking them in the night, you would even have to remember to take them. Here the routine is, before you do anything else, drink your meds. You drink it with a glass of water. Excellent health advice as well, to drink a glass of water early in the morning as soon as you're up. Please tell me, how can you not do well? And then before I used to say when you brush your teeth, but some people say I don't brush my teeth. Sounds like it's fine.
Oh my!
I was like, it's fine. As soon as you get up and you hit the bathroom is when you do your meds, and you never ever forget.
Sure.
So you want that kind of confidence and that knowledge to go to patients, and I promise you, if you impart that bit to people, you're on a roll. They look after themselves. They understand how easy it is. Then, the other thing is the cost factor. ARVs cost next to nothing. Absolutely next to nothing. I say to patients, if you can afford 10 rands a day, that's the price of your ARVs. You can't even get a can of Coke for 10 rands a day today. So it is so simple to access. And we have no side effects, please. All the drowsiness, dizziness, bad dreams, fat distribution, no bums, no legs, big back, all of that is all in the past.
Sure.
And now we have an aging population. You must remember our patients are older and we got them smarter. Our drugs are so smart.
That's very interesting. And as a clinician, do you continuously do research? Do you guys have spaces, teams, groups? How do you work around continuously getting more info and evolving the treatment process?
So, like I said, we're getting smarter. The one field of medicine that's just moving is the HIV field. So, not last year, the year before, I'd been to a conference in Glasgow and picked up that they were using new drugs. When I got back, I spoke to the doctors and the managed cares here and I said, listen, there's a new drug available, can we roll it out? They said, for sure. And I can't even tell you, I mean, the new drugs are just game changers, not just in terms of how they work and how safe they are, but also in terms of their price, but more importantly, the pill size. They just work like magic, absolute magic. So, for instance, we used to have drugs in the old days that could impact on the kidneys. Now you have drugs that don't impact on the kidneys. In the old days, we had drugs that didn't have high barriers to resistance, and nowadays we have drugs that have such a high barrier to resistance. I mean, we're just on a total roll. Our drugs are so potent. They have no side effects. I'm telling you, just take one in the morning when you get up, and you're as good as new.
So, Dr. Kay, tell me, this is the consulting room where you always meet with your patients to do your work as a clinician. What other work do you do outside this office?
If I'm not treating patients, I'm also training doctors in how to treat. Like I said, our drugs are better and newer all the time, and you want to share this knowledge with others. So I do a lot of training for drug companies, for NGOs, for whoever wants a training of doctors, the Clinician Society, whoever says, Kay, would you, the IMA, whatever. We train doctors and pharmacists as well in how to treat. And you want to impart that knowledge to your colleagues. No use you sitting here and you know what to do, but you're not going to reach everyone out there. So we do conferences, we do online, whatever you call it, stuff where doctors get trained all the time in how to treat patients as well. But also, you want to let them know what's new and what's not new. It's like last year I did 2 trainings I call the trainings Time to TAF. We have a new molecule out there called TAF. So that's what I named it, Time to TAF, letting people know this is a new molecule. Try and get your patients exposed and initiated onto the newer, better meds. Because every day we have newer, nicer stuff. So try and move patients onto that. Sometime in February, I work at Garden City Hospital. Garden City will have a major CME, and I'll do the HIV training, not just for our physicians and doctors, but whoever else wants to attend, and all the GPs in the area as well. So a lot goes into training as well.
Sure. And where do you see yourself beyond 2030?
I have patients that come in here all the time and they say to me, Dr. Kay, we hope you're training everyone else, because if you are not here, who's ever going to see us? And I hope in a happier space. I'm saying I hope in a happier space, but I'm like in a super happy space right now with how well all my patients are doing and how well, how beautiful the drugs are that we have right now. But just to say to everyone that if you're on the old drugs, and I'm going to name them like TE, which is what we know as doctors, you need to get all your patients off it. If you're taking Alluvia, Lamzid, all of that, which I call rubbish, you need to get your patients off that and put them onto the newer, nicer stuff. Not only is it more potent, but also the pill size is smaller. It's a whole new game changer that you need to upskill yourself as a doctor so that you can pass that confidence down to patients. But more than that, you need to change their meds from the old meds that they were on previously and move them onto the new meds that are available now.
So when new meds are rolled out, is it started from hospital level to clinic level? Is it like a national rollout? How come then we have doctors, as you're mentioning, that would still be using meds that are not really working or are labeled as old meds?
Yeah, but also remember, I'm also covering the private sector as well, not just the government sector. And the access to treatment in government and private differs a little bit. In private, we have access to more stuff. Generally, government is doing like a major rollout for mass people, whereas in private, we can be a little more, I can be a bit picky and choosy about what I would give you because we do have access to more stuff. So that's the kind of rollout you want to people in private to say you have more options. You know, don't just give everyone the same thing. Individualize. If you think this patient has this viral load, this patient has this renal issue, this patient has this liver issue, you have a lot more options. And then also, when you're switching meds, because patients fail meds, do understand there's a process that gets followed. You need to understand that process as well, because sometimes people do fail treatment. And when they do, you need to know what to do. So you also need to understand that.
Have you planned your retirement age? Have you decided, or are you just going with the flow up until...
I generally say that I think everyone should work for God. And I don't think there should be a limiting factor in that. For as long as you're functional and you can give back to society, your payback is from God. You don't need to worry about anything. He'll take care of you. If you look after humanity, He takes care of you back. And I live by that.
You speak highly of God, and you sound like somebody who's very spiritually in tune. Would you say that's what sets you apart, or that's what's giving you your winning formula since you've started this journey as an HIV clinician?
And knowledge, God and knowledge. And in fact, we have a problem with I have a problem with my receptionist, you know. She'll say to people, this is what I charge. And then when they leave here, she'll tell me, did you take money from them? And I'll go, no, it's fine. So I think when your heart is in the right place, you don't need more than that. You really don't need more than that. I think in life, humanity has lost it. I think everyone thinks it's all about money. Life is not about money. It really isn't about money. And I think if you can change people's lives, there is nothing, no amount of money that's going to make you feel good.
So have you seen the rewards, taking exactly from what you've just said, have you seen the rewards of that attitude and mentality in your life?
I don't even have to see it in myself. I see it in my patients even. I mean, I would have a patient who'll come in here and she is so sick. I mean, so sick. And then we will give her a liver transplant. And she'll be so perfect where I'm even going, wow. You know, I mean, even I can't believe how well she's looking. I have a patient who will be coming in here who's on dialysis and is taking like so many tablets. And I would readjust his meds and he's taking 1 tablet a day. You know, and just to look at that face, you know what I mean? You don't need more than that. You know what I mean? It's and like I say, for the patient to walk in here and say, "Where's my darling doctor?" You know what I mean? It's just like a given. And like I say, when patients come in here and they come in with 3 kids and I'm getting 3 lollipops from each one of them, I mean, now really, what can make me feel better?
That's priceless. And from your own children, how old are they now, and is anyone following your footsteps?
So I have 4. I have 3 have gone into the medical field.
Wow.
And 1 is a lawyer.
Okay. Wow, so, that old. So how old is the youngest now?
The youngest is 24 years old.
Wow. It's been quite a journey, hey?
It has. And the oldest is 35.
Wow.
And yeah, they're good kids. They've grown up with good values and very hardworking and good kids. So
in terms of the 3 that are in medicine, is anyone following this specific path?
No, they are veering towards Dad's path.
Which is?
The eldest is doing cardiology now. Dad is a cardiologist, so he's following Dad's footsteps.
I see. So in your family, nobody goes to the doctor. You have everything in house.
They do. They see the dentist. Remember?
Oh yes. I mean, but for these other stuff, like mom can tell me what's wrong, dad can tell me what's wrong.
No, sometimes life tests you differently.
Yes.
So sometimes we are forced to see a doctor for whatever reason, and then we have.
Sure, that's very interesting.
But like I say, I think the simple rule is do good and good will come to you. Very simple rule. Just be good, do good, good will come to you.
Very, very interesting. And in parting, Dr. Kay, what is your message to the young ones, to the older ones, whether someone is living with HIV or not living with HIV? What is your message, and how would you want to be remembered one day when people are talking about your history, your legacy, what you did in the HIV field? How do you want to be remembered?
I want the population out there to remember that the most important thing is knowledge. You know, whatever it concerns, the more educated and the more knowledgeable you are, I think that's a winning streak. So when you're knowledgeable, whatever it is, and you can share that knowledge with other people, whether it is your colleagues, or whether it is your patients, or whether it is anyone you interact with, and you can change that life just by imparting that knowledge, I think you've stood out in life more than anything else. And I think that's what makes a difference between me and other doctors. Because when you come in here into my rooms the first time, we spend like 10 or 15 minutes knowing that you understand exactly what's what. Because like I said, you will get killed. But and if you can understand that ARVs mean nothing. What's important is your drugs. And if you can take it every day, but if you have a problem, I'm here. You come straight back to me with any issues you have, and we're going to sort it out. But I can't drink your meds for you. You need to drink your meds. And if you stagger anywhere along the way, you come back and chat to me and we will work around it. And I think if you can impart that knowledge to say, listen, HIV is not the issue is a viral load. And what I need from you is for you to drink your meds. Any issues, you address it with me and make sure your viral load is undetectable. Not only are you imparting that knowledge, you're imparting that confidence to that patient. And that is absolutely important as well, that they need to understand that, you know what, as long as I'm taking my meds, I'm as good as you, and that's all you need to sell. And as the doctor, you got to make sure you're giving them the best meds. You're most up to date with what is going on. You know what's new. You know what is best. You don't want to give what is old. You don't want to give what has side effects. You need to also just keep up a little bit with the new trends and new meds. And then it's just such a win-win situation.
Absolutely. Is there anything else that we may have left out that you want to add?
I'm
as
just
we
going
wrap
to
up,
summarize it.
Yes.
everyone needs to test. And if you test, you're either positive or you're negative. If you're positive, you're going to go on to ARVs, and your viral load has to be undetectable. And it's my job to make sure you have no side effects. But it's your job to drink your meds. And if you're negative, then you have multiple choices. You can either depend on the partner's undetectable viral load, you can take oral PrEP, and like I say, round about April, you'll have access to the injectables. But what I also want to let everyone know, especially the young girls, is that what is most important is you. And then, like I said, is an education. So if you mix up the order of things in life, you will pay the price. Please don't. Women, young women, don't. Understand what's important is you and education. And if you get that right, you will reap the benefits down the line. If you do not, you will pay the price. And I once remember reading somewhere, it's books before balls.
Thank you so much. Thank you so much. And this is how we wrap it with Dr. Kay Mahomed, an HIV clinician who's been in the field for over 20 years. And this is the MOL podcast. Thank you.